Hello, everyone. Welcome to your renal lecture on nephrolithiasis, aka kidney stones. Please be sure to review your uh, reading assignments and any of your learning resources linked in your course. So what's a clinical presentation of somebody with nephrolithiasis? Well, that's going to depend on the size and the location of the stone. Smaller stones may be less worrisome. Larger stones can cause far greater symptoms and far greater pains. Be sure to review the information in your text table 44.2 on page 646 for the types and causes of stones and the tests that can be done in table 44.3 on page 647. These people come in, oftentimes they're in such great pain. And sometimes it's just this horrific back pain, but oftentimes it's like this flank colicky pain. They've got frequency. They could be vomiting. If they have a big process with this, they could be diaphoretic. They look sick and they act sick. So getting subjective information collected can be a problem sometimes because they can't hardly sit still sometimes. Objectively, you're going to do a good evaluation of the abdomen. Is it distended? Do they have guarding when you're trying to palpate? Do they have flank tenderness? What are their bowel sounds like? They're in pain. These people are going to have potentially elevated blood pressure and elevated heart rate, and they may or may not have fever. The list of differential diagnoses that could be in consideration would be appendicitis, diverticulitis, pancreatitis, ileus, peptic ulcer, ovarian cysts, ectopic pregnancies, gallbladder disease, or cholecystitis, right? Abdominal aneurysms or malignancies. Diagnostic testing, a urine dip in the office oftentimes will show hematuria. If you have the luxury of being able to do clinical microscopy in your office, you will see on the clinical microscopy lots of red blood cells, and the presence of what we call crenated blood cells is often a tip-off to that this is a nephrolithiasis. Kidney and bladder ultrasound may give you information. IVP used to sort of be the gold standard. Now really CT technology is more definitive for this particular diagnostic. So what's your management? So be sure to review your medical treatment. Really, we don't do a whole lot if we have collected information on a diagnostic test and the stone is less than 5 millimeters. So, a pencil eraser is what? 3 or 4 millimeters. So this is about the size of a pencil eraser, maybe. That still seems big to me, right? It usually passes spontaneously. It's going to cause pain and symptoms, but we're going to manage with some non-steroidal anti-inflammatories or some pain medications. Greater than 10 millimeters is not likely going to pass on its own, so you may need to look at different type interventions for that. Please look at table 44.2 and 44.4. Some of those beyond the pain management of nonsteroidals or narcotics in the form of hydrocodone or Tylenol number 3, or maybe even Percocet, right? Maybe if the patient's nauseated, we might give them some Zofran. Off-label use of the alpha blockers could be considered, and maybe also the use of a calcium channel blocker could be considered, but like they said, that's off-label use. Certainly, a urologist could go in there and put in a ureteral stent. Interventional radiologists could do percutaneous nephrostomy, and large nephrolithiasis, sometimes they will do bust those up with ultrasound. Referral, Yeah, maybe for pain management, you might need an emergency room. The ERs probably, they might do the diagnostic testing and get you an answer faster. Urologist or nephrologist, depending on, if the patient, this isn't the first bout of nephrolithiasis, things need to be evaluated for that. And then, as we said, interventional radiology, you might need to do that for the percutaneous nephrostomy. Here are your references and your resources for this lecture material. Thank you.